So we'll get started. Good morning, everyone. Thank you so much for joining us for these really important pivotal sessions. We're talking about Team Birth, if you heard our prior conversation and some of our email blasts that went out. Today, we'll be jumping into a Team Birth, one of our first Team Birth mini learning sessions. So today, we'll be going through the process, the innovation, clinical safety, and effective communication around the dignity and childbirth of this really important tool. Taking a few steps back, my name is Christine Ivory. I'm a program officer here at the New Jersey Healthcare Quality Institute. I'm joined by my colleague and our Director of Quality, Adelisa Perez Hudgens, and we are so excited to have Dr. Chen join us from the West Coast on this call from Ariandi Labs. Just a little bit of a brief introduction about us. The New Jersey Healthcare Quality Institute is the only multi-stakeholder nonprofit for New Jersey. So we have partners and great stakeholders and members all throughout the state of New Jersey. And we work together for safety, quality, and affordability of care for all. And with Ariandi Labs, I did write down a little brief, succinct introduction that you all are a joint center for health system innovation at the Brigham's and Women's Health Hospital from Harvard Chan School of Public Health. So I want to make sure that I'm getting all of that in, Dr. Chen, as you are representing Ariandi Labs on this call. I'm going to quickly move on because we know that this is a mini session, but we just want to talk about the importance and why we are here today. So setting the groundwork for Team Birth, we are all very familiar with the stats and the data around maternal mortality, infant mortality, and a lot of the different issues that are faced. So we won't read everything on the slide, but we know that a large portion of deaths within the United States are preventable. In fact, the CDC report that over 80% of these pregnancy-related deaths are preventable. In New Jersey, that we know that Black women experience higher mortality rates within the nation in our home state of New Jersey. And we can see from the slide that 3 to 4 times more likely is something that we all know, but within New Jersey, it's over 7 times, or at least 7 times more likely. So we just want to draw attention to this. Now, we know that a lot of these different errors and preventable deaths or sentinel events can be due to errors in communications or gaps in communication, right? So when we're thinking about in our units and our departments, communication with each other, but then also communication with patients, and that's where Team Birth comes in to strengthen the connections that you already have at your hospitals with your patients and to really just forge ahead with a really great innovative tool. So I'll move along here. This is just a slide to show that representation of Team Birth. Representation of Team Birth is all throughout the state of New Jersey. We are in 18 hospitals throughout the state of New Jersey, and that is over half of the birthing hospitals and centers throughout the state of New Jersey. And our main goal is to go statewide with Team Birth with this innovative care process throughout the state of New Jersey. And Dr. Chen, I'm sure you'll mention how Team Birth is all over the United States as well in over 150 hospitals throughout our nation and also internationally as well. All right, so we'll go into the Team Birth background and overview next. And actually, I want to pass this torch over to Dr. Chen for that background and overview. Thank you.
Someone else is going to move slides for me though, right? Yes? Or do I have to?
Christine will do the slides for you.
Thank you. So when we talk about Team Birth, we know that most of the unexpected adverse outcomes that occur in obstetrics are due to poor communication, right? We know that. In the state of Washington, that holds true almost every adverse event we look at, whether it's medical legally or just at peer review at a hospital level. There's typically been a breakdown in communication. I think this is a great pictograph that shows communication as it's been. So I've been practicing since 1990, I don't know, when did I, in the 90s. And this is typical communication. The nurse will have a conversation with me, often outside of the room. Then they'll go back in and tell the patient what I said. The patient will say to the nurse, "Oh, I don't really like that. Can you call Dr. Chen again?" And the nurse will call me back. It's quite linear. I think if we're humble and willing to be introspective, we say, yes, this is probably how we've been used to communicating. If you go to the next slide, the purpose of Team Birth is to really change that change that model so that communication becomes more circular and really that patient becomes the center of communication. I think the other thing to keep in mind, and I say this all the time, is that I, as a patient, will never lack agency or lack the ability to participate in my care because I am in healthcare, I'm educated, and I'll just be able to do that. But if you look at a lot of people who are giving birth, they walk out of their birth, they've had birth trauma. Often it's from not being respected. And it's just something we're not going to experience. So I think you have to take that in mind and say, you know, it's hard to imagine for me. It's hard to imagine that so many women walk out of childbirth and say they weren't listened to, they weren't respected. From a maternal mortality perspective, what we have seen in the state of Washington is in a lot of our deaths, women did not seek care. And they probably, in a lot of cases, the lack of seeking care, the root is lack of trust in our healthcare system or having been disrespected in the past or lived experience. So I think we have to change the narrative in how we take care of pregnant women who are coming in to give birth if we're going to move the needle on maternal mortality. But this is really the model of TeamBirth, is to say, how do we get out of the linear pattern? How do we do patient-centered communication, whether it's at the bedside through a speakerphone? So if we go to the next slide. So the purpose of TeamBirth, and again, this is something where we know as obstetrical care providers, most of the time when something bad happens, it's because we didn't communicate well. If you have these structured team huddles, the whole point is to bring the team together, whether it's really together physically at the bedside or whether it's bringing in, you know, people by phone, right? For me, as when I started this, I labored my own patients while I was in clinic. I did a lot of my huddles via speakerphone. The second part of TeamBirth is that there's a shared planning board. So as Christine said, in every hospital across, whether you're in the US as a TeamBirth hospital or you're in Sweden or you're in Nepal, you have a shared planning board that has the 4 key elements that you can see there. We'll go over the elements. But it's a visual tool that structures the communication so that it ensures that we communicate the same way with every patient every time, regardless of any of our own biases as to what we think that patient wants to be communicated to them. So if you go to the next slide. So TeamBirth huddles, you know, who's involved in the huddle? It's really the entire care team, including the labor people, support people, and particularly doulas. I think we're now seeing that doulas are very much welcomed into our maternity care space. A lot of that, again, comes to basically patients needing an advocate, somebody who they trust, who can help to make sure that they're being heard. So the who is really everyone who's going to be in that room and everyone who the patient wants to be part of that team. So I have had patients who have wanted somebody to come into the huddle by speakerphone, and I've allowed it because really the point is to create a safe space for the person who's giving birth. The what is in the lower corner, there's a part on the board called preferences. And I think that preferences isn't really just putting up a birth plan. I don't know how many of your patients have birth plans. I would say that, you know, where I am in the various hospitals in Washington, it's probably about 50-50. Some of our patients come in with having been very thoughtful about what matters to them. Others don't. But I think the point of discussing preferences is really to elicit what matters to this patient and their team. What can I do to give you the most amazing birth experience ever? And I think you find interesting things the more you are willing to go into depth about preferences. And that's how you create a good birth experience. That's how we create equity. Because what matters to the patient in room 1 may not matter to the patient in room 4. But our job as a team is to figure out what matters to them. I have, you know, so many examples, but I had a patient who the biggest thing on her preferences was, please make sure I get my antibiotics for groupie strep. I tend to not use that board for medical things, but for that patient, when I asked her, what is one of the most important things for you in this birth? She said, please don't forget my groupie strep treatment. And it turns out she had a friend who didn't get Group B strep treatment, and her friend's baby died. So I wouldn't know that. I wouldn't know that that really mattered to that patient if I didn't ask, but it mattered to her, and it was helpful to her to have us acknowledge it, put it on the board, even though we know in the back of our minds, my team was like, well, we always treat for Group B strep. Doesn't matter. What mattered for that patient was that we heard her preference, we honored it, and we actually put it on the board, gave it a space in the room. When we talk about when to do huddles, oh, and the rest of, as I go on with what else is in the huddle, it's everyone in the team putting up the preferences, outlining a plan of care. And it's amazing how putting that plan of care visually on the board, so the team remembers what the plan is, the patient and the family remember what the plan is, and then the next huddle. I think I will say, you know, now that I'm 25 years plus into this, I think one of the most important things that the patients like is when I leave the room, I sort of say, okay, I'm planning to be back in about 4 hours or sooner if you need me. When I'd be on the phone, I would say, okay, you know, I'll call back in about 3 to 4 hours, or call me if you need me. The points for doing the huddle, this is not prescriptive. You know, what we recommend is that at admission, because that is obviously when you're first establishing what the plan is going to be for labor. I think that's the most important time to set the stage for patients, to give them the expectation that, you know, we will honor their team, their preferences. So I think admission is a big one. Major decision points. I think that if you're thinking about starting to have conversations about C-section, and I remember, you know, in my past, I would often have the conversation with the nurse outside the room or on the phone. I would say, hey, I think your patient is kind of circling the OR drain. If you could kind of prep her a little bit. It's hard for me to recognize that this is how I used to practice. I don't do that now. I have that conversation with the patient, and it has really actually made my life better to have that level of transparency. It's been much better for the patients as well. The other thing is that if you're going to change a plan, like if you've made a plan, but now all of a sudden, you know, the baby's having variables, and you think you might have to do an intervention, going in talking about IUPC, amnio infusion, that's a great time to have a huddle as well, because you're talking about an intervention. I use the TeamBirth huddles a lot at night if I have a cervical ripening or early induction admission. I think it's nice at the beginning of the night to set the stage. I get much fewer phone calls when I actually set it up and say, plan is that we're going to do 1 dose of misoprostol now. Typically, it takes a second or third dose. So in 4 hours, the nurse is going to do this. If that looks fine, we'll go ahead with the second dose. It's what we call, you know, this started in Oklahoma. They call it the tuck-in huddle. So you basically tuck in the patients, but with a very clear plan, it reduces the number of phone calls you get. And why we think TeamBirth huddles this way, I think the biggest thing, again, it's patient-centered communication. So we're not talking about the patient outside the room. And the other thing is that it's important to really allow all the team members a chance to participate in the decisions. And I will say, you know, I remember when we started TeamBirth, I had a very new young nurse. The patient had been 7 centimeters for 4 hours. So I went in to start the conversation about, you know, I think we need to think about C-section. And at the end of the huddle, you know, I asked the nurse, I said, do you have any thoughts? You know, what do we want to, are we comfortable with proceeding? And she said, give me 1 more hour. I just want to try a few more positions. And at that point, the baby was looking fine. Patient was motivated. She said, sure, let's try another hour. And an hour later, after, I don't know, crazy position changes, that patient was complete. So I bring that story up because I do think there is a lot of benefit in empowering every person in that team to really actively participate in the care of the patient. And when my hospital started TeamBirth, I was at a pilot site for TeamBirth. So this is 2019. I've now been whiteboarding for 5 years, and I've made whiteboarding into a verb. But when we started this project, our goal was really to try to reduce our C-section rates. And we did drop our C-section rates significantly by using this model of shared communication and really involving everyone in the team. So our NTSV C-section rate went from the low to mid 30s down to mid 20s. And that's why my hospital engaged in it, but why it's continued and why many of the why it's going out statewide is because we saw such success in how the patients responded to this form of communication. So 2 hospitals in the state of Washington were pilots. We are now rolling it out statewide through all of our maternity hospitals. And is that my last slide? Is that my last slide? I think that might be my last slide. Oh, this is again, just a picture that shows you this is a standardized TeamBirth board. Every board that exists in a TeamBirth hospital has these 4 spaces on there as a minimum. And you can customize your boards. I think that's one of the funnest parts of starting TeamBirth is you can customize your board to add things if you want to. But the premise of the board is to really focus on these 4 elements. And the premise is to really say we're going to huddle the same way with every patient every time that it's necessary and really give patients the birth experience that they're hoping for. And I think that's it.
Thank you so much, Dr. Chen, for giving us that background information and your personal experience, utilizing the TeamBirth huddles and the TeamBirth board. I'm going to talk just a little bit about TeamBirth research and really focus on New Jersey data that we've collected so far. So if you want to go ahead to the next slide. This is really just to indicate and highlight that there is some published research about TeamBirth. There's 3 main articles that focus on it: the design, the primary outcomes, and the implementation of TeamBirth. Of particular interest to clinical providers tends to be the TeamBirth implementation one. It talks about barriers, but really they interviewed over 100 clinicians for their feedback and perspectives. And so that has a lot of good information. And then more recently, towards the end of last year, Ariandi Labs issued a newer article focused on the implementation of a shared decision-making program in labor and delivery, really focusing on how TeamBirth is a model for person-centered birthing care. So we do encourage folks to check out those articles for a little bit more about the research behind TeamBirth. And if you want to go to the next slide. So this slide really looks at the research that Ariandi Labs has been able to do statewide. They are in more states and hospitals than indicated here, but this slide really just speaks to the opportunity they had to work extensively, for example, in Oklahoma, where they had an almost 90% Medicaid population and worked in lower resource environments than their pilot sites. And so regardless of the populations and resources available, they've really seen extremely good, successful implementation and outcomes, and has launched statewide in 3 states. And we hope for New Jersey to be one of them. As my colleague indicated, that we're in 18 birthing facilities, which is more than half. And we do plan to implement statewide and have interest from many more hospitals. So we do see that something that will happen in the coming years. If you want to go to the next slide. So this is a look at TeamBirth data in New Jersey. This was as of March or April this year. So we've collected a little over 1,300 surveys from patients. So this is feedback directly from them, and we've collected much more since. But what you can see here are the MADAM items. And so TeamBirth uses the mother's autonomy and decision-making, or MADAM scale, to assess childbirth experiences. This is an evidence-based tool that includes 7 questions focused on communication with the healthcare team, education on options for care, and the birthing person's involvement in decision-making. And so in this chart, the blue bars represent birthing people who reported they did not experience TeamBirth huddles, and the orange bars represent birthing people who reported they did experience TeamBirth huddles. And so if we look at the first item on the left, involved in decision-making, we see that 66% of birthing people who reported they did not experience TeamBirth huddles felt involved in decision-making during childbirth, whereas 88% of birthing people who reported they did experience TeamBirth huddles felt involved in decision-making during childbirth. And so we can see the clear benefit and desire for clear, structured communication. And we see similar trends across all of the MADAM items where there is lower autonomy for birthing people who report they do not experience TeamBirth, compared to higher levels of autonomy for birthing people who did experience TeamBirth. We are also able to look at our data by race and ethnicity. If you want to go to the next slide. We see some of that data here. We're just doing some snapshots, but on the left represents patients or birthing people that did not participate in a labor huddle. And then the chart on the right are birthing people who reported they did participate in a labor huddle. This is just looking at the percent of strongly agree responses. It is a Likert scale. And so same thing on the left, we can see that there are varying levels of autonomy. So there are some disparities. Particularly for the Black African American population, they're reporting 56% strongly agree that they felt involved in decision-making when not involved in a team birth huddle. When we look at the right, we see much more alignment across the populations. There's over a 20-point increase for white, Black, and Asian respondents. And then just pulling out again that example for the Black African American population, they went from feeling 56% strongly agreeing they were involved in decision making to now 85% strongly agree that they felt involved in decision making. So again, we see that large increase, but we also see the disparities lessen. There's much more alignment across populations and feeling having that higher level of autonomy and feeling involved in shared decision making throughout their care. If you want to go to the next slide, this is just one last example of how we look at each MADAM item by race and ethnicity. Again, on the left, we see the disparities, variability in levels of autonomy for choice, respect, whether the birthing person felt or strongly agreed that they felt their choice was respected during labor. And then on the right, we see all of the scores come over 90%. So these patients, birthing people who did participate in team birth huddles, strongly agree that their choice was respected during labor and delivery. And we see that alignment across all of the populations. And if you want to go to one more slide, we also look at the quartiles. And so we look at MADAM quartiles by race and ethnicity and huddle status. And again, you can see all of it for each population. The bar on the left are the birthing people who indicated they did not have a team birth huddle or they were not sure if they had a team birth huddle. And then the bars in the right are the birthing people who indicated that they did have a team birth huddle. And I think if you click one more time, it might highlight. There we go. And so this is those who indicated with high autonomy that they felt involved in shared decision-making and autonomy. And so particularly for the Black African American population, 52% of patients or birthing people who did not experience team birth had high levels of autonomy. Whereas for Black African American patients, birthing people that did experience team birth, 89% were reporting high autonomy. So we see that increase in autonomy levels. And then again, across race and ethnicities, the autonomy levels are all near or over 90%, and there's much more alignment. And this data is particularly meaningful here in New Jersey, where we have some of the lowest autonomy scores that Ariandi Labs has seen across the country, and particularly, again, for the Black African American community population, that change between high autonomy for birthing people not experiencing team birth compared to birthing people that do experience team birth, that is one of the largest increases that they have seen. And so we do talk with sites about their specific data. So we report site-specific data back to them. And then we also are looking at New Jersey aggregate data, which are the slides that I have been talking to you about today. And so if you want to go to the next slide, I'll stop recording and we'll do a little bit of Q&A if anyone has questions.